So imagine asking a 14-year-old, someone who is suffering from acute trauma, to just log on to an iPad.
Yeah, and expecting them to explain their darkest, most vulnerable moments to a total stranger.
Right. And now imagine asking that exact same teenager to do it all over again the very next week.
To a completely different stranger on that exact same screen.
It's wild. But that is exactly what happens when school districts try to cut corners with, these generic gig economy telehealth platforms,
Yeah, it doesn't just fail, it actually pushes the student further away from getting any help.
which is terrifying. Because, well, welcome to today's deep dive. Today we are looking at a stack of operational data and internal logistics for a system called MentalSpace School.
Right, which is a K-12 mental health support program operating across Georgia right now.
Exactly. And the mission for this deep dive is to get past all the political buzzwords, the vague promises about supporting our students. We really want to look at the actual boots on the ground logistics of how a modern school mental health partnership actually functions.
Because it's hard. When you try to jam clinical healthcare into the heavy bureaucracy of a public school system, it is usually a disaster.
Oh, absolute disaster. And, for you listening right now, whether you're a parent watching these systems fail your kids, or maybe an educator who is just drowning in paperwork, or just someone fascinated by how complex societal problems are solved, this is for you.
Yeah, it's really a masterclass in organizational design because most administrators, they just live in fear of these partnerships.
Right. They see it as just another headache.
Exactly. When a district decides they need to tackle mental health, they typically default to one of two deeply flawed models. The first is like the detached vendor.
The ghost in the building, essentially.
Right. A company basically drops a counselor into a spare office at the high school, maybe every other Tuesday. That counselor isn't part of the faculty, they don't know the school culture, and they just operate in total isolation.
Which helps no one. And then what's the second model?
The second one is the bureaucratic nightmare. So a district adopts this highly complicated program that looks fantastic on a PowerPoint, right?
Oh, always looks great on the slides.
But in reality, all it does is pile a mountain of new administrative intake forms and data entry onto the school's existing staff.
So the school counselors, who were already managing hundreds of kids, end up doing more paperwork instead of, actually talking to students.
Exactly. But MentalSpace, they completely reject both of those flawed models.
Wow.
And it starts with this very basic realization that you cannot fix a problem if you refuse to measure it accurately.
Right, which leads us to what they call the Insight Survey.
Yeah, step one. Before any therapist is hired, before any program is launched, the institution itself has to undergo this evidence-based diagnostic.
Okay, let's unpack this a bit, because this seems like such an obvious first step, yet it's almost rarely done in public schools.
It's skipped all the time.
Right, and we were talking about a 20-minute, completely confidential, no-cost assessment.
And it captures an incredibly wide net of data.
Yeah, it looks at the specific mental health needs of the student body. Like, are we dealing with high rates of trauma? Or maybe a sudden spike in substance abuse or widespread anxiety.
But it goes beyond just the kids, too.
Right, it measures resource gaps, like the current counselor-to-student ratio or the wellness of the teaching staff.
Which is huge.
And community challenges, like the lack of rural transportation or specific socioeconomic factors in the area. It's like, well, it's the difference between buying a one-size-fits-all suit off the rack versus going to an actual tailor.
That's a great way to put it. And what's fascinating here is how this data-first approach prevents the massive waste of resources that plagues so many of these public-private partnerships.
Because mental health isn't a monolith, right?
No, not at all. A rural school in South Georgia has fundamentally different sociocultural needs and totally different community stigmas than a dense urban school in downtown Atlanta.
So if a district just buys some off-the-shelf, quote-unquote, anxiety reduction program, but the school is actually suffering from a localized substance abuse crisis,
the intervention is totally useless.
it's like pouring an ounce of concrete to build a massive suspension bridge before you've even bothered to map the geography of the riverbank.
Right, you have to survey the bedrock first.
Exactly. If you don't know the exact currents and the specific density of the soil, that multi-million-dollar bridge is going to collapse.
Yeah.
You wouldn't let a doctor prescribe you heavy daily medication without taking a diagnostic blood test first. So why do we let school districts adopt generic mental health benchmarks?
Honestly, we let them do it because it's easier. A generic program just requires less thought.
Yeah, sad but true.
But by mapping that bedrock first, MentalSpace ensures the output isn't just some national average. It is a hyper-specific custom picture of that exact school at that exact moment in time.
Which naturally leads to the next hurdle.
Okay, so we have a precise map of the school's psychological landscape. We know the dimensions of the problem.
But identifying the problem isn't the same as solving it.
Right. Who actually delivers the care? And based on the diagnostic survey, they build these custom modules. Custom modules like same-day teletherapy, suicide and violence prevention, which is tailored specifically for grades 6 through 12, and family counseling.
And the crucial secondary trauma support for the teachers. But the mechanism that actually delivers all this care is what I have found really surprising.
The dedicated therapist team.
Yes, a dedicated team.
That is the single most important operational choice in this entire system.
Wait, okay, I have to challenge this from an efficiency standpoint.
Mm.
Because if I look at the broader tech landscape right now, almost every major telehealth app operates on a rotating pool.
Sure, yeah.
You log on, the algorithm finds the next available clinician, and boom, you start your session. It is incredibly efficient for a company to manage their workforce that way.
It is efficient for the company.
Right. So why is MentalSpace spending the time and the money to assign a specific, dedicated team of K-12 licensed therapists to one specific school? Why not just use the rotating pool?
Because efficiency in a tech algorithm does not equal clinical efficacy. Especially, and I can't stress this enough, especially when you are dealing with adolescents.
Okay, so it's a demographic thing.
It raises a massive point about the psychology of trust. Continuity of care is the absolute cornerstone of trauma-informed therapy.
Right, going back to the 14-year-old we talked about at the very beginning of the deep dive.
Exactly. If that student finally works up the courage to talk about, say, domestic abuse at home or severe bullying, I mean, the emotional toll of getting those words out is staggering.
It takes everything they have.
It physically exhausts them, their cortisol spikes, the defense mechanisms flare up.
So if they log on the following week and have to start from zero with a brand new therapist,
Who's basically just skimming their file for the first time.
yeah, that actively re-traumatizes the student.
The teenager feels totally unheard. They get frustrated, they shut down, and they simply stop utilizing the resource. The whole intervention fails completely.
So by assigning a dedicated team, the student sees the exact same culturally competent therapist every single time.
Right, they can actually pick up where they left off.
That makes a lot of sense.
But the benefits of that consistency extend way beyond just the individual student-therapist relationship. Because these clinicians are dedicated to a specific school, they start to really learn the ecosystem.
Oh, they pick up on the local dynamic.
Yeah, they start to understand the local slang, or they realize the whole town is currently stressed because the major factory just shut down.
Or they know about, like, the tragic car accident that happened over the weekend involving a senior.
Exactly. They become a digital extension of the community, and operationally, this allows for what clinicians call warm handoffs.
Warm handoffs. Okay, as opposed to a cold handoff,
Right. A cold handoff is a student filling out a sterile web form and just waiting for an email.
which is awful.
A warm handoff is a trusted teacher or a school counselor who already knows the student well, personally introducing them to a therapist who is already a familiar, trusted part of the school's safety net.
I love the idea of the warm handoff. But honestly, that actually introduces a massive structural friction point in my mind.
How so?
Well, if you are embedding a highly trained, dedicated team of outside clinical therapists into a high school, aren't the existing school counselors going to feel incredibly threatened?
Oh, the turf war.
Yeah, you are basically invading their turf. I'm thinking about the reality of the faculty lounge here. Doesn't bringing in external experts make the existing staff feel obsolete? Or imply that they just aren't doing their jobs well enough?
It is the #1 reason these external partnerships get sabotaged from the inside.
My bad.
The internal staff actively rejects the outside vendor, but MentalSpace operates entirely on a coexistence strategy. Their whole philosophy is to act as an extension of the school's reach, never a replacement.
How does a district actually enforce that boundary, though? Because the line between extending and replacing seems very, very thin.
It requires a rigorous division of labor and just constant communication. They hold weekly coordination meetings between the school's existing counselors and the MentalSpace clinical lead.
Wow, weekly.
Yep. And they develop joint crisis response protocols.
Okay, I want to pause on that coordination piece. Because sharing information between a public school and a medical provider is notoriously difficult.
It's a nightmare.
They have to navigate this incredibly tricky legal intersection. I mean, on one hand, you have TALPA, which fiercely protects a patient's medical and psychiatric files.
Right.
And on the other, you have FERPA, which governs the privacy of a student's educational records. Merging those two without breaking federal law usually paralyzes school boards.
Oh, it completely paralyzes them. It requires building a secure, highly compliant, bureaucratic firewall where these shared care plans can exist safely.
So how does that work in practice?
Well, the school counselor knows the student's academic standing and maybe behavioral issues in the hallway, right? That falls under FERPA.
Okay.
The mental space therapist holds the deep clinical diagnoses under HOPA. But by coordinating weekly, they can discuss the student's overall progress and adjust the interventions without illegally exposing raw medical data to, say, a math teacher, or vice versa.
So they are really acting as a unified front.
Exactly.
But the real genius here seems to be how they divide the actual day-to-day workload to avoid that turf war we mentioned. The analogy that comes to my mind is the difference between a general practitioner and a specialist.
That is a perfect way to look at it.
Right. Like the school counselor is your primary care doctor. They see you every day. They know your history. They help you navigate the system, and they handle the immediate, localized issues.
Yeah, but a school counselor is drowning.
They are managing hundreds of kids. They literally cannot provide 50 minutes of deep cognitive behavioral therapy to a student suffering from PTSD.
They just don't have the time.
So when they identify that need, they do the warm handoff down the hall, or in this case, through the platform to the specialist.
Right. MentalSpace takes the heavy, time-intensive clinical therapy load completely off the school counselor's plate.
Which frees the school staff to do what only they can do.
Yes, they can get back to academic scheduling, college prep, building relationships in the cafeteria.
And doing immediate crisis triage when a fight breaks out in the hall.
Nobody's toes are stepped on because everyone has a distinct, highly respected lane. It elevates everyone's capacity. The school counselor gets to be an educator and a guide again, rather than acting as a makeshift trauma psychiatrist.
Okay, so the school has been diagnosed accurately. The custom, dedicated clinical team is in place. The legal minefield of HIPAA and FERPA has been successfully navigated. And the internal staff is working seamlessly with the external specialists.
Right.
But trauma and anxiety do not conveniently clock out when the school bell rings at 3:00 p.m. This system has to function in the real world, after hours.
Which is why the infrastructure provides a 204/7 safety net. We are talking about same-day assessments for new student referrals.
Wait, same day? In the current landscape of adolescent psychiatry, finding a therapist with availability can take weeks, sometimes months.
I know. Providing same-day access is a massive operational feat.
And they back it up with 247 crisis access for students and families, maintaining a 99.5% platform uptime, which is crazy for a school platform.
It really is.
But I really want to look at the outcomes. Because all of these logistics, the diagnostics surveys, the warm handoffs, none of it matters if the kids aren't actually improving.
Absolutely. And the numbers coming out of these participating schools are really striking. The academic correlation is impossible to ignore.
Yeah, we're seeing an 89% improved attendance rate among participating students.
89%.
That's massive. 76% of them see better grades. 92% report reduced anxiety. 85% family satisfaction.
And crucially, 90% of the school staff report feeling better equipped to support their classrooms.
So what does this all mean? When I see that attendance jumps by almost 90% and grades improve by 76%, it just completely reframes the entire conversation around mental health and education.
It's not just a nice-to-have wellness perk anymore.
Right. It isn't just about making kids feel happier. It is the fundamental building block of academic performance.
If a student is paralyzed by an untreated panic disorder, or if their nervous system is completely hijacked by acute trauma at home, they cannot learn algebra.
The cognitive load is simply too high.
Their brain is literally in survival mode. You can have the most brilliant, highly trained teachers in the entire state, but if the student's psychological bedrock is crumbling, the educational bridge will not hold.
But implementing a 247 clinical ecosystem to fix that bedrock sounds unbelievably expensive.
Oh, it sounds astronomical.
To sustain those kinds of outcomes, you need a flawless financial engine. And public schools do not have massive untapped budgets just sitting around waiting to be spent on clinical therapy.
Funding is the ultimate roadblock. Usually, if a school wants a new program, they have to go to the community and try to pass a new tax levy, which is, well, incredibly difficult.
Almost impossible in some districts.
But the organizational design here bypasses the school budget bottleneck almost entirely.
Hmm.
They don't rely on the school's discretionary funds.
Okay, so where does the money come from?
They tap directly into the existing commercial healthcare infrastructure.
Wait, how does a public school district actually execute that?
Well, MentalSpace operates entirely in network with Medicaid.
Oh, wow.
Yeah. That means for any Medicaid-eligible student, the clinical care costs $0 out of pocket.
$0.
Zero. And on top of that, they're in network with all the major commercial insurance providers, the
Yeah.
big names that most working families already have.
So instead of the school trying to scrounge up the money to pay for the therapist's hourly rate out of the education budget, the therapist simply bills the student's existing healthcare provider.
Just like they would if the student went to a private clinic across town.
That is brilliant.
Precisely. They basically turned the school into a functional node on the existing healthcare grid. It minimizes the budget impact on the school district to almost zero, while maximizing access for the students.
So the financial burden is shifted away from the educational system and back to the healthcare system, where it actually belongs.
Exactly.
It is a huge conceptual shift. But there is another piece to this compliance engine that is causing a lot of panic in Georgia specifically right now, and that is House Bill 268.
Right, the looming legislative deadline. This is a perfect example of how complex these logistics actually get.
So for those unfamiliar with it, HB 268 is a piece of legislation in Georgia that places very strict, legally binding mandates on schools regarding how they handle mental health interventions and crisis response protocols.
And the deadline for full compliance is July 2026.
I can only imagine school administrators are absolutely terrified.
They are.
They are principals and superintendents, right? They're not healthcare compliance officers.
But the state is essentially demanding that educators act like hospital administrators. And if they fail to meet these really complex legal requirements by July 2026, the school faces serious penalties.
So MentalSpace uses that panic as part of their value proposition.
Definitely.
They have built HB 268 compliance support directly into their operational model.
By bringing them in, the school effectively outsources that massive legislative headache.
That makes total sense. The dedicated clinical team ensures all the crisis protocols are legally sound, that the HIPAA and FOPA intersections are perfectly secure.
And that the school is fully shielded and ready for that 2026 deadline.
It creates a perfectly sustainable ecosystem. The deep clinical needs of the students are met. The financial model is viable because it leans on existing insurance.
And the terrifying legal mandates from the state are fully satisfied by actual experts.
It shifts the paradigm completely away from treating mental health as this, like, outsourced afterthought, and instead integrates it as a core, load-bearing pillar of the educational infrastructure.
Yeah, it really does.
Well, we have covered a massive amount of ground today, tracking the journey from that initial 20-minute diagnostic survey that maps the bedrock of a school all the way to a fully functioning, financially sustainable clinical engine.
We've seen how a dedicated team builds trust.
How they navigate the friction of joining an existing faculty by staying in their specialist lane.
And how leveraging Medicaid completely changes the financial reality for school boards.
It's fascinating. But I want to leave you, the listener, with a final thought today, something to mull over long after this deep dive ends. We have just explored a model where deep, complex clinical therapy is safely offloaded from overwhelmed teachers onto embedded community healthcare networks.
Yeah.
If logistical models exactly like this successfully scale nationwide, what does the fundamental architecture of a school actually look like a decade from now?
That's a great question.
Because if educational institutions can seamlessly integrate with the broader healthcare infrastructure, the rigid line between a traditional place of learning and a comprehensive community wellness hub might just disappear entirely.
They could become the primary access point for pediatric healthcare.
Exactly. What would that mean for the next generation of students? Because if we have learned anything today, it's that you can't just cross your fingers and hope the system holds.
No, you definitely can't.
You have to measure the currents, map the geography, and build a framework that actually supports the weight of reality. Thanks for diving deep with us.